So now we're ready to talk about the care of the patient with musculoskeletal trauma. And for this unit, we're going to talk about soft tissue injury and the treatment modalities for that. We're going to talk about fractures. And we're going to talk about some treatment modalities for that. We're going to talk about cast care, how we care for it as nurses, how we teach our patients to care for themselves, and what kind of complications can come from that. We're going to talk about traction. And traction can be skin traction, like your bucks traction, and that is a non-invasive type of traction where we put weight on the extremity to keep it aligned and reduce muscle spasms, and we use the patient's position as a sort of counter traction. And there's skeletal traction. And skeletal traction involves pins that are inserted into the patient, and their traction is maintained through the use of a frame. We will talk about external fixation devices. And your external fixators are kind of interesting to look at. They can help immobilize a fracture, reduce muscle spasms, and get the person moving earlier. And there is also internal fixation. And those of you who have had patients with intertrochanteric fractures, I know there was one student in our group who had a patient who had that nail placed, the intermedullary nail, into the femur. And it's sort of, that's what internal fixation is. You take a screw and you join those bones together. That can either be done as an open reduction with internal fixation, where the surgeon has to go in and surgically manipulate those bones, directly manipulate those bones so that the ends meet. Or it can be a closed reduction internal fixation, where the reduction part of it, getting those bones to meet, is done without a surgical incision, and then the fixation device is placed. So that's what we'll be talking about for the next few slides. Okay, we're ready to talk about soft tissue injury. And you'll find more information about this on your Hinkle text 56 through 60, 1156 through 1160, and chapter 43 is where we're working. Just a little bit of a word about your textbook. This textbook jumps around a little, in my opinion. You talk about cast care, and then you talk about fractures. I'm going to do it the opposite way. With most of your med-surg content, you're going to talk about the disorder, and then you're going to talk about the treatment of the disorder. And I'd like to start following that format because I think it's more helpful to you to organize that information. Also, chapter 43 talks about amputation with musculoskeletal trauma, and although there are traumatic amputations, we will mostly be concerned with other types of trauma, fractures, and soft tissue injury. We will cover amputations, but we'll cover them separately after we do osteomyelitis, because most of the amputations that are done in this country are done for non-traumatic, for example, diabetes or peripheral artery disease that leads to maybe infection or necrosis of the extremities. Okay, so under soft tissue injury, back to our topic, we're going to start with contusion. A contusion is just a bruise. It's basically a collection of blood under the skin. We all know what black and blue marks look like, and usually they're caused by blunt trauma. For example, you're playing soccer without your shin guards. Someone kicks you or the ball hits you, and you develop a contusion. Normally, they are self-limiting. They're done within a week or two. They go in stages of healing. We all kind of remember they go from that purpley to like more of a greenish and yellowish, and finally they disappear. The only real treatment for it is ice and elevation, if that, but they are self-limiting. And then we can talk about strain, and strain is an injury to a muscle or a tendon, and this normally comes from overuse or overstretching. For example, you lift that big heavy box and ow, you feel something go out in your back. That can be muscle strain. There are 3 degrees of muscle strain. There is first degree. Oh man. Back to typing school. Okay, first degree muscle strain. involves some mild stretching of the muscle, and you'll see people get a little bit of swelling, mild pain. Generally, they don't lose function. And then we have second degree strains. And second degree strain is a partial tearing of the muscle or tendon. This person has more pain. They might not be able to lift or bear weight on the affected muscles. There is edema. There's tenderness when you palpate. There may be muscle spasm, and you might see some bruising with a second degree strain. And then you have third degree strains. Third degree muscle strains involve severe stretching or rupture of the involved tissue, the muscle or the tendon. This person is in a lot of pain. There is muscle spasm, there may be bruising, there's edema, and the person cannot function. Your book says that at this point you should do an x-ray. When a tendon tears, it sometimes forcefully tears a piece of bone away with it, and that's called an avulsion fracture, avulsion. Let me just put that in there. I had an avulsion fracture once from a severe strain that I got on a spinning bike. The tendon tore away and took a little piece of bone with it. The care was very similar to what you would get for a severe strain or sprain. And we're going to kind of talk about that. Here, let's get rid of that. We'll put that back here. And talk about sprains for a minute before we go back to the treatment for these things. A sprain is an injury to the ligaments and tendons that surround the joint. So where a strain is a muscle tear, a sprain is the ligaments and tendons around the joints. You sprain an ankle, you sprain a knee, you sprain your shoulder, but you would strain your back or you would strain your quadricep, if that's kind of clear to you. If not, go back to page 1157 in Hinkle and Cheever and sort of get that straight in your head. Usually a sprain is caused by twisting motion. You're moving that joint in a way that is not consistent with its range of motion. So a knee that twists instead of moves up, flexes and extends like a hinge joint can be sprained very easily. Ankles can be sprained. And normally what you see is swelling, pain, severe, mild to severe pain, but normally it's pretty bad. And you'll see tenderness, the joint will be tender, and movement is painful. And that's sort of the key to a sprain, is that this person does not want to bear weight on the affected joint, and movement can be very, very painful. When they're immobilized and at rest, the pain is relieved. So again, we have first degree, second degree, and third degree sprains. And we'll go back into that. A first degree sprain is caused by stretching the ligament fibers, and you have minimal damage. You have some swelling, some tenderness, and some pain when the joint's moved. A second degree sprain. A second degree sprain is partial tearing of the ligament. So just like with the muscle, when you have mild, it's first degree. When you have some tearing, it's a second degree. This is more painful. You have more edema. You have more pain with motion, and now that joint is unstable and this person can't function normally. So if they were walking and now they've sprained a knee or an ankle, they can't walk. Or they are limping. They maybe have that antalgic gait associated with limping. And a third degree sprain. Third degree sprain is a complete rupture of a ligament or tendon. It can also cause an avulsion fracture. And this person has severe pain, tenderness, increased edema, and abnormal joint motion. And you do have to rule this person out for fractures because it can be very hard to tell what's underneath all the swelling. So, here, you know what? Let me get rid of this because we've seen that before. And I'll put this up here. And now we're ready to talk about this RICE acronym. We're not going to get to dislocations just yet. We'll get there. But this is something you might see again. That's why I put a star next to it. It's a very common acronym. Probably most of you remember if you were ever involved in sports. REST. Okay, and by rest, we want that person not to use the joint. So if it's a weight-bearing joint, the knee, the ankle, the hip, we want them to be off their feet for a little while. We might also want to immobilize the joint so that it doesn't get used, because remember, movement is painful with these soft tissue injuries. Ice. The I is for ice, and we use cold. Your book goes up to 72 hours after the injury, and cold produces that vasoconstriction and decreases the edema and the bruising that's associated. It also works with that gait control theory that we talked about back in our pain management lectures. Ice sends a signal to those nerves that kind of cuts off the pain signal. So ice can be very, very comforting to people. Compression. Compression is a lot of times used with an ACE bandage. And what that does is it kind of keeps that edema down and provides support for the injured tissue. And the last word in our acronym here, elevation, when you elevate the extremity, you decrease the pain and you also decrease the edema. So RICE is a good acronym, and we can use RICE really for the first 24 to 72 hours after injury, depending on how severe it is. And here, let me kind of make that a little bit bigger. Take some time, write a note to yourself, but remember RICE. Most of you probably already know it. If you've ever torn a muscle or had a sprain, somebody told you about it. Generally, the injury can be self-limiting if it's a first-degree strain or sprain. That person can be up and around in a few days. But severe sprains and strains can take up to 6 weeks, and you might want to immobilize it. Range of motion exercises can be started depending on the severity of the exercise between 2 days and maybe 4 to 6 weeks after. It can actually take your soft tissue injuries a little bit longer to heal than bone, because bone is more vascular. So sometimes people with strains and sprains, especially the third degree kind, need to take it slower for longer. And it is possible to create an injury that keeps bothering that person for a long period of time. So you really want to caution this person to follow their doctor's instructions with that. Okay, so moving on to dislocation of the joint. Dislocation of a joint is any time where you have two bones that were supposed to meet and they no longer do. The distal and proximal ends no longer approximate, and they're not in proper alignment. You can have subluxations, which are a partial dislocation, or you can have a complete dislocation. This can be an orthopedic emergency. Your book alludes to that. Because there's a lot of blood vessels and nerves that can get trapped, and you can end up with a condition called avascular necrosis. We did have a patient up on 2A with a AVN of the hip that necessitated a hip replacement. And dislocation is actually one of the complications of hip replacement if we don't take care. So what we see when we look at a dislocation includes pain, we see deformity, we see a shortening of the extremity, and we see decreased mobility. And here, let me fix that so you have all the words at one time. So those are the things that we look at. So if you were to have, say, a patient, status post total hip, and we will cover that in more detail later, but just a little sneak preview. You have a patient, they were discharged, they come back, they're in a lot of pain, and now you look and one leg looks shorter than the other and there's a lot of swelling, and they can't walk on it. You would suspect that that patient dislocated their prosthetic hip. And I'm going to look and see if I can find a picture of that for you, if you just give me a minute. And there we are. That is a guy with a dislocated shoulder. And I'll show you right there. See that bump? That is the head of his bone protruding out of that socket where it no longer meets. So care of the patient having a dislocated joint immediately that joint needs to be immobilized. So we might put it in a sling, or we might put it in a brace, but we need to immobilize that joint, and then it needs to be reduced. And that means that the two displaced parts have to be put back together. So if you've got that shoulder that's popping out of the joint, someone is going to have to pop it back in, and this is a painful procedure. And in order to do this, we have to decrease muscle spasm, or else that joint won't go back. So the doctor will probably give that person some pain medication, muscle relaxant, and maybe even anesthesia to make that reduction happen. And then we're going to immobilize the joint and give this person some exercises to do, some range of motion within what the provider has decided is safe. After the reduction, if this person is casted, or even if they're in a brace, the most important assessment we're going to do, remember, there are blood vessels and nerves that could have gotten trapped with this dislocation. So we're going to do neurovascular checks. And we're going to talk about neurovascular checks now, and we're going to talk about them again with fractures. Okay, well, you might get sick of hearing me talk about the 5 Ps, but the 5 Ps are an important concept, and in fact, I'm going to put a star next to them. There we go. The 5 Ps are pain, paresthesia, pallor, paralysis, and pulselessness. Now, whenever you have an injury where you suspect that there might be any signs of neurovascular compromise, for example, with a dislocation, remember we said that there were nerves and blood vessels that lie at those junctures where the joints are, that they can get trapped and that permanent damage can result. So these are the signs and symptoms of neurovascular compromise. Pain. That person will have intense pain, especially when you put them through a passive range of motion. Okay? Paresthesia. Burning and tingling numbness. Patients who report this after an injury, whether it's a fracture or a dislocation, you need to be aware that this is a sign of neurovascular compromise, and it's very serious. And if you don't act on it, that person can get permanent damage. Pallor. Again, you're looking at circulation. So if you look distal to the injury, whether it's a fracture or a dislocation, and you see pale extremities, pale cold extremities, that's something that needs to be reported. Because either there's a lack of circulation or the nerves aren't functioning right, but that person is not getting blood flow. And if you ignore it, that person is at risk for serious permanent complications. Paralysis. You're going to ask the person, can you wiggle your fingers, wiggle your toes? Can you flex your wrist? And you're going to make sure that that person can still move. Again, distal to the extremity, you want to make sure that that person still has motor and sensory function. And pulselessness. Now, if a person's casted and you can't reach their radial pulse, you can still check capillary refill, and this will tell you whether or not that person has blood flow. If you can check the pulse, you should. Always check the pulses distal to the injury. Now, this was one of those interesting dilemmas when I was researching cast care. If for whatever reason you can't assess a pulse on a patient, let's say they have bilateral arm casting, and you can't get to the radial pulse without digging under that cast, which you cannot do. For your vital signs, you're going to check that apical pulse, but you're still going to look for signs and symptoms of circulation, and that you're going to do by capillary refill. And you want to see that it's less than 3 seconds, usually less than 2. But those are your 5 Ps. And again, they're starred. They're important. You need to know them. It's just, this is the basic assessment that you do when somebody has musculoskeletal trauma. So now your book gets into some detail with these, and I'm going to skip the greater detail. But these are some common orthopedic injuries that involve the soft tissue. Rotator cuff tears, very common. It's a tearing of the tendon that holds the humerus bone to the shoulder joint. And treatment for this can be NSAIDs, it can be physical therapy, or it can be surgical debridement using an arthroscopic procedure. Your knee injuries, the collateral ligament injuries, cruciate ligaments, and meniscal injuries. Generally speaking, again, there's first degree, second degree, third degree. The first degree injuries will be managed with rice and with some NSAIDs, some anti-inflammatories. In any of these joint injuries, you may see doctors inject cortisone into the joint, or there may have to be physical therapy and even surgery, after which there's a period of rehab and the person should wear a brace to give more joint stability. Ruptured Achilles tendon, generally it's people who do like explosive sports activities. You'll see older adults, the weekend warriors, can rupture their Achilles tendon. It's very, very painful, and generally it can be casted, but surgical repair is generally avoided because it's really not associated with better outcomes. So those are some of the disorders that your book talks about. I wouldn't get too heavy into them unless you have a patient who needs something and has had that surgery. But for purposes of studying, this is sort of a minor point. Okay, so it's time to talk about fractures, and fractures are a substantive part of the content for Unit 8. So I'm going to refer you to pages 1160 through 1168 in your Hinkle and Cheever book. You'll also find out more in Chapter 41, which deals with the treatment modalities. As I said, your book kind of organizes the material a little bit differently, but I'm going to be consistent with the way that we study most pathophysiologies, and I'm going to discuss the pathology first and then the treatment. And you'll notice that there are a lot of overlapping things. For example, when we talk about osteoporosis, one of the main ways that we can diagnose it or suspect it is that the patient has a pathologic fracture. But this is different than the traumatic fracture, and since we're still talking about musculoskeletal trauma, we're going to keep it pretty simple and just talk about the basics of fractures. So there are different types of fractures. There are complete fractures, and they occur when the break goes across the entire section of the bone. So you have two separate bone fragments. There are also incomplete fractures. And these fractures don't go all the way across. So for example, when we have a green stick fracture, which I'll show you a picture of, one side's broken, one side's bent, the fracture does not go all the way across. There are also different types of fractures. So let's take a look at some of the pictures that we have here. And these are fractures of the long bones. We have normal bone all the way to the left, and then moving from left to right, there are transverse fractures. And transverse fractures are across the horizontal plane. It's straight across the bone shaft. This is a pretty easy fracture to reduce as long as the fragments are in close proximity to each other. Then there are oblique fractures. Oblique kind of go at an angle. There's transverse, there's oblique. They're a little bit harder to reduce than your transverse fracture. So, but because they occur at an angle and sometimes those bone fragments don't want to come together. Now a spiral fracture, I'm going to call your attention to this. A spiral fracture generally occurs when there's a twisting motion, and it can be a red flag if you are dealing with a child and you think that that person might be abused. It twists all the way around the shaft of the bone. In this picture it looks like a oblique fracture, but it's pretty obvious when you see this in real life. You'll see it kind of come that way, where the fracture just twists all the way around the shaft of the bone. Comminuted fractures have little tiny bone fragments. Here, let's kind of reduce that a little bit. These can be very difficult to reduce and put back together. Avulsion fractures, we talked about them twice with sprains and strains and a little bit with our dislocations. Avulsion fracture is when a tendon pulls away from the bone so forcefully it takes a little piece of that bone with it. Impacted fractures, These occur when bone fragments are driven into each other, one bone fragment into another. Then we have fissures. Fissures are cracks in the surface of the bone. And you see these a lot with stress fractures. It can be repeated loading of bone or muscle. And green stick fractures. Green stick are very common in your pediatric patients. Their bones are a little bit more flexible and capable of withstanding a little more impact. So what you'll see is a fracture where one side of the bone is broken and the other side kind of bows in a little bit. Okay, so then we get into your simple or closed fractures. And let's take a look at one of those. This picture should be pretty familiar. That is a simple fracture. You can see that the skin's not broken. The bone is obviously deformed, but it's under the surface of the skin. Then we have our compound or open fractures. And I'm going to show you a picture. This is an illustration. I didn't want to get too graphic, but certainly if you have that morbid sort of curiosity and you want to look on the internet, there are dozens and dozens of pictures of people whose bones are poking through their skin. And I'm going to show you right here. That is where the bone fragment pokes through. Now, the biggest problem with open fractures are that you have now not only a broken bone but a wound, and you can very easily get an infection in that bone. When we're talking about open fractures, we grade open fractures on a scale from 1 to 3. A grade 1 is least severe, and this is where you have minimal skin damage, less than 1 centimeter, and there's a clean wound. And we have grade 2 when there are skin and muscle contusions. This is a larger wound. There's more extensive soft tissue damage. So this is a more serious compound fracture. And then we have stage 3. And stage 3 is the most serious, highly contaminated. It has extensive soft tissue damage. May or may not be accompanied by traumatic amputation, and it is the most severe. Okay, so how do we know that a bone is fractured, or how do we suspect it before we take an X-ray? There are certain characteristics of fractured bone, number one of which is pain. So this pain is continuous, it is severe, it is a sharp, sudden pain associated with an injury. You can have muscle spasms that aggravate this pain. Generally speaking, if you immobilize the extremity, the pain is reduced. So those are the characteristics of pain of a fracture. You have loss of function. And that should be pretty obvious, especially when you look at pictures of fractures, like this one. Here, let me put that in perspective there. This guy's not going to walk on that. It's the same thing when we looked at the hand fracture from earlier. I think this is probably the third time I've shown it to you. But obviously this guy's not going to be able to do anything with that hand until we reduce that fracture and it heals properly. In addition to loss of function, we have, deformity. And that's you know, pretty obvious right here. You'll also have shortening of the extremity. And the reason you have shortening is pretty obviously, instead of the bone being one straight continuous line, some of those bone fragments might line up with one another, so that this right here is a little bit shorter. It's not, you know, it's not that straight line. Okay. Another characteristic that you might find is crepitus, which we've already spoken about. We spoke about it in Nursing 137 in the lab. I'm sure everybody's instructor talked to them about crepitus. And we talked about it earlier in this presentation with palpation as an assessment tool. Crepitus is that grating sensation or grating sound, crumbling sound, that happens when two bone fragments rub on one another. And like I had addressed with you guys before, once you assess it or once you feel it, stop looking for it. If it's present, that's the end. You're not going to keep trying to elicit that. And then localized edema and ecchymosis. And this comes from the overall trauma to the area as those tissues fill with blood and fluid. And this might take a little while to develop, but usually when you have a fracture, you have these signs. Okay, so now we're dealing with emergency management of fractures. What to do if you are out somewhere in the field and suspect a fracture. Let's say that you're at a roller skating rink and someone falls, and when you look at that person, they're in obvious pain, you see deformity, you see swelling, you see loss of function, so you suspect a fracture. The first thing that you do is immobilize. You want to splint that, that extremity, supporting the joints above and below where you suspect the fracture. And that should be pretty obvious just by looking at the person's leg. And if you don't have a commercially made splint, and most people don't when they're out having a good time, you can use something that is sort of semi-rigid, like a blanket folded up, or newspapers folded up. If you have boards and you can pad them pretty quickly, that would be a good splint. But you definitely want to immobilize the joints above and below. Before and after you splint, you're going to look at your 5 Ps. And let's get them up here. Pain, paresthesia, pallor, paralysis, and pulselessness. Okay, and there's a pretty good reason I keep showing you the 5 Ps. And the reason for that is that you're going to see it again. And most likely when you get a question, it might not say, what are the 5 Ps, or what are the signs and symptoms of neurovascular compromise? What the question is going to ask you is, or what the question is going to do is pose a scenario. The person has an injury and you splint it, and the person then complains of tingling and burning, and they can't move their toes, and their feet are cold and pale and have no peripheral pulse. That would tell you that there's neurovascular compromise. So just get yourself really familiar with these terms, because it comes up again and again when we're talking about disorders of the musculoskeletal system. Okay, so I would like to show you guys a video, if you just pardon me for a moment.
I'm Chip Myers, a paramedic with the City of Alexandria Fire Department in Alexandria, Virginia. Next we're going to talk about how to treat somebody with an extremity fracture of the lower leg. Over here we have Josh, who's laying on the floor, complaining of pain in his leg. He's got a swollen area in his leg. He felt a popping sensation or snapping sensation. We know this is very painful to the touch, and there may be even some false motion or some kind of, feels like some grinding sensation when we check the area. First thing we did is we measured out 2 wart splints, and then one on the inside of the leg, one on the outside. These board splits, you can use anything you have around the house that's long enough to fit the leg. A broomstick, anything. Ideally, try to pad it with some towels or something, but if you don't have anything to pad it with, putting the splint in is better than nothing. If you have nothing at all that you can splint the leg with, you can use the good leg and tie both legs together. When splinting, you want to put 2 triangular bandages or 2 cravats, or if you use tape, anything that you use, but you want to put 2 on the upper leg and 2 on the lower leg to try to hold the splint in place. The idea is we're trying to minimize any motion in that leg, in that fractured area. And that will help reduce the pain for this person, plus it will help reduce some of the swelling and damage to the soft tissue as well as the blood vessels and nerves in that area. When tying the cravats or the triangular bandage, we want to make sure not to get so tight that you actually cut off the circulation to the foot. So if the patient starts saying that they've got a tingling sensation in their foot, or that their foot starts to turn purple, you might need to loosen up some of the cravats. Next, we're going to talk about how to treat somebody who's got an ankle injury. Josh here has an injury to the ankle on the other foot, and we're going to wrap that in either a blanket or a pillow to try and stabilize it. You want to use something bulky, something soft. If you're at the ski slope and somebody else has this problem, you could use a down jacket. So you just position the ankle, base the heel of the foot on the center of the blanket or the pillow, and you wrap it up around the foot, and you just tie it in place or tape it in place, whatever you have handy. So that's how you stabilize fracture of the lower extremity.
So the emergency treatment. Okay, so the treatment of open fractures is going to be a little bit different from the treatment of closed fractures. The first thing you're going to do is cover with a sterile dressing. If you don't have something sterile, use the cleanest thing you have. But sterile is definitely preferred. You can apply pressure if there's a lot of bleeding. Try to control the bleeding. But the main complications from open fractures, obviously, you're not just looking at a fracture, but you're looking at a wound. So we're looking at the possibility of osteomyelitis, which is usually caused, again, by Staph aureus. And we're looking at gas gangrene also, and tetanus. So what we want to do is cover that wound with something sterile. If we have to apply a little bit of pressure, or well, as much pressure as you need to control bleeding, you don't want to try and reduce that fracture or in any way take those bone fragments any more out of alignment than they already are. And you want to transport that person as quickly as possible. They need to get right to the OR. They need a tetanus shot. They'll probably need the surgical debridement and an external fixation. So that is your management of the open fracture. You're also going to try and immobilize, but your priority intervention is going to be to prevent the complications of infection and bleeding. And for that, you're going to need to cover with a sterile dressing. Okay, so now we know we have a fracture. How does the body respond? We're going to talk a little bit about how bones heal themselves. They need a little help from us most of the time, but here's a picture that shows the body's response to a fracture. And the body responds immediately when a bone is broken. And the first thing that happens, I'll kind of circle that for you. There's a hematoma. There's bleeding. Bone is very, very vascular. It has a good blood supply of its own. So what happens when the bone breaks is it's going to bleed into that tissue, into the space between the bone fragments, and form a hematoma. Okay? Gradually over 24 to 48 hours, you're going to have the development of granulation tissue. And that healthy granulation tissue will start laying down collagen. New blood vessels are going to be formed. We're going to have angiogenesis. And as the blood vessels start laying down the collagen and the fibroblasts, we're going to get what's called a soft callus. And there is your soft callus. This picture is showing it as a fibrocartilaginous. I prefer soft. And cartilage will fill in that space until the osteoblasts lay down spongy bone, and that is your hard callus. Eventually, that spongy bone will be replaced by normal bone tissue in the process known as bone remodeling. Excessive bone fragments will be reabsorbed, and it's really a neat process if you think about it, that the body knows just how to do this. So now that we know how the body heals itself, we can talk about how we, there we go. How we can support or prevent impediment of this process. So let's talk about the factors that support healthy bone growth. And for this, I'm going to refer you to table 43-2 on page 1164 for a more complete understanding of this. And I don't want you to memorize it. I want you to have a deep understanding of how bones heal, how we help them to heal, and how we prevent malunion or non-union or complications of fracture healing. So when you look at the things that enhance fracture healing, obviously if we're relying on a good blood supply, we need to ensure a healthy blood supply. Okay, so we're going to control risk factors like arterial insufficiency or smoking. We're going to try and convince that patient not to smoke. We're going to do all the things we can to ensure the healthy development of new blood vessels. Okay, we're going to control diabetes, other conditions that can impair good blood supply. We need to immobilize and reduce that fracture. If we can get that fracture, the bony fragments, to join in a good alignment, and we can keep that nice and still so that we don't interrupt that healing process, we can really help the body's natural defenses and repair mechanisms. Okay, so proper nutrition. In order to have a healthy blood supply and in order to lay down new bone, we need good nutrition. We need good protein. We need vitamin A and vitamin C for collagen formation. Remember that one of the things that happens when that hematoma forms is it's going to lay down collagen. Well, if you don't have vitamin A and vitamin C, it's going to be very hard to do that. We need calcium and vitamin D so that the calcium's absorbed. We need magnesium. We need phosphorus. We need those things so that the body can supply the osteoblasts with the things that it needs, the things that they need. We need to make sure that hormones are balanced. So the people with thyroid disorders, people with parathyroid disorders, people who maybe need steroid therapy, we need to monitor those people for impaired bone healing. Okay, so now that we know some of the factors that enhance fracture healing, we're going to talk a little bit about things that impede bone repair. Okay? And first and foremost is the failure to immobilize and reduce. And this should make pretty good sense to people if you think about it. If those bone fragments aren't making contact, or if something is constantly disrupting that growth process, you're not going to have proper union of the fragments. You're not going to have that nice process of hematoma to granulation to soft callus to hard callus to remodeling. If something is constantly disrupting that, or if there's a lot of space between the bone fragments where they can't establish that healing process, you're going to have problems. Anything that impairs blood supply. For example, if you have extensive soft tissue trauma and that constricts the blood vessels surrounding the bone, that swelling kind of interferes with the development of a good blood supply, you are going to have delayed healing. If you have chronic diseases such as vascular disease, diabetes, any kind of condition that's going to impair your blood supply, including things like smoking, lifestyle habits. That's going to be an issue. If you have improper nutrition, if the body can't make all the ingredients to give you a healthy bone, obviously you're going to have delayed healing. And then there are things like chronic diseases, because they interfere with the normal metabolic process of bone healing. Things like Paget's disease of the bone, things like cancer. If you have local tumors that interfere, and a lot of times, unfortunately, with cancer, you do get fractures because of bone metastasis. If you have thyroid disorders or Cushing's syndrome, or again, diabetes is another one. If you have all of these chronic conditions, you're going to have problems with bone healing, because either the hormonal aspects of it, or the vascular aspects of it, or whatever the bone. If it's osteoporosis, for example, if you can't form healthy, strong bone, or you can't maintain the bone you have, it's going to be harder to heal a fracture. And then lastly, you have things like non-adherence to treatment. And these are the people who cut off their own casts. We all know them. People who the doctor will tell them you need to be off your feet for 6 weeks, and they're still up and around, and I know he told me I'm not supposed to be on my foot, but I'm going to do it anyway. People who smoke, people who maybe don't follow the nutritional advice, people who don't follow their cast care guidelines. These folks are at risk for impaired bone healing. Okay, so we're moving on to medical management and treatment modalities for fractures. So you did your job in the field, and the patient got to the emergency room, and now the doctor is going to do a reduction. And reduction means that those fragments of bone are going to come back into alignment, into a position where the bone's natural healing mechanism can occur. Okay, there are two types of reduction. There is a closed reduction, and closed reduction is the least invasive. And that is accomplished by the doctor manipulating the bone from the outside and using manual traction to get that limb in a more anatomical alignment, to make sure that the bone fragments can communicate with each other. And then there has to be immobilization so that that reduction stays where it is. So generally speaking, we're going to do some casting. And in the next slide, we're going to talk about plaster casts, fiberglass casts. Or we can use various splinting devices. And splints and braces have taken over a lot of the more extensive casting, like body casting. Not seeing that as much as we used to. And we'll talk about cast care a little bit more. Traction is something that is also used. Sometimes it's used while we're waiting for surgery, especially with pelvic fractures. There are two types of traction for fractures. There's skin traction, and Buck's extension traction is one type. We're going to talk more extensively about that. Where we use the body's weight as counter traction, and we're just kind of pulling externally on the skin. And there's skeletal traction, and skeletal traction involves the placement of pins through the bone, and then these bones are hooked up to the pins are hooked up to an apparatus that maintains traction. Traction used to be like the gold standard of fracture care. This was something that was considered like state of the art. This is the way to go. Not so much anymore. There hasn't been a clear benefit to traction shown in the last Cochrane analysis in 2012. And I'll give you guys some references for that if you're interested. They didn't see a clear benefit to having skin traction after a pelvic fracture prior to surgery. There are still some docs that use Buck's traction, I'm told, but not as many. Skeletal traction really is hardly ever done. You see more external fixation devices, and the reason traction fell out of favor really was that it limits mobility and it takes forever to work. So people would end up with complications of immobility, the bed sores, the DVTs, And the skeletal traction had always the risk of osteomyelitis. So what you might see more is like an open reduction and internal fixation for some of these folks. And an open reduction is more invasive than the closed reduction. This is a surgical approach, and the doctor will make an incision, and through that incision directly manipulate the fracture fragments so that the bones are in alignment, and then they'll put in pins or wires or plates or some kind of screws. There's a lot of good pictures of it, which I'll show you when we do that part of the lecture. And this ensures better healing than some of the other methods, but it is more invasive. External fixation devices are also used. These are pins that go through the skin, and then there's usually like a big frame on the outside. And the advantage of external fixator devices are that it promotes better healing and early mobility. Now, with open fractures, there's a whole series of interventions that we do to prevent infection, and the first thing that person is going to need is a tetanus shot. Then they're usually given antibiotics. Now, those antibiotics can be given through the IV. Generally, vancomycin is one of the preferred methods. I'm going to show you another very interesting way to do that. And this is a beading technique. I apologize. When I use this program, sometimes the pictures just kind of pop up from nowhere. This is an external fixator device, and these are beads of, they're impregnated with antibiotics, and so that is put directly onto the wound surface. So it makes contact with the bone, it makes contact with the soft tissues, and helps to prevent infection. Now, this can also be used to treat osteomyelitis, this technique. However, prevention is obviously much better when you're talking about osteomyelitis. Because of the risk of osteomyelitis, the other thing that's going to happen is that wound is going to be irrigated and debrided in the operating room as soon as possible. There might be wound cultures taken of the area, and sometimes there are bone and muscle grafts that occur. Skin grafts occur sometimes a little bit later. Usually that wound is left open, and that permits wound drainage. It allows you to assess the wound, and it allows further debridement of the wound as necessary. The other treatment modality that you're going to see more with the open fractures is the external fixator devices. You can't cast an open fracture. It's just not wise. You don't want to have that open wound stuck in that moist, dark, warm environment. So that will be where you see a lot of the external fixation devices. If there is any kind of damage to the vessels or to the nerves in that area, that will also be okay. In conjunction with the different treatment modalities, you will see some medications being used to help treatment. And we've already talked a little bit about tetanus toxoid, and this is a booster shot when we have an open fracture and we worry about tetanus. The patient may get a tetanus shot. Anticoagulants such as heparin, Lovenox. In some cases you might see longer-term therapy with Coumadin or some of the newer anticoagulants, the oral ones like Eliquis. But most commonly, if the patient is on bed rest, you're going to see heparin and Lovenox. Blood clots are a major complication of certain fractures, particularly fractures of the pelvis and of the femur. Can happen with any of the long bones, but particularly with those. We also give antibiotics. Again, this is for open fractures or for anything that was reduced via open reduction technique. Or if there's any kind of skeletal traction or external fixation where there's a portal of entry into the bone. You may see nutritional supplements ordered for people, vitamins, iron, anything to improve the nutritional status, and that will help healing. And for pain, we might see opioid narcotics. You might see those medications being used, especially initially, the first 48 to 72 hours. After that, most of the time, if you have adequate immobilization and reduction, you can give that person NSAIDs. Even acetaminophen can be used, although it's more common to see the NSAIDs because of the anti-inflammatory effect. So occasionally we need to worry about complications of fractures, although normally with good care, fractures should heal relatively well. Sometimes we see some things go wrong. And your book mentions a few. The page numbers that we're looking at are 1164 to 1168. And anytime you have trauma, you can have bleeding. Anytime you have bleeding, you can have shock. So the signs and symptoms of shock, and this isn't specific to fractures, it's just one of the things your book mentions. You can have tachycardia, you can have lowered blood pressure. When that volume goes down, the heart still wants to pump out fluid. So you know stroke volume times heart rate equals cardiac output. When you don't have enough fluid, your stroke volume gets smaller. So to compensate, the body increases the heart rate. But because the cardiac output is decreased, there isn't enough blood pressure. So you'll get tachycardia and hypotension at the same time. When you're palpating pulses, you'll feel weak, thready, rapid pulse. The patient will complain of anxiety, sometimes be very panicky. And you will see pallor if the shock is from bleeding. So the treatment for shock is going to be supportive. We're going to replace the fluids as rapidly as possible. And I've seen doctors hang fluids to gravity. You don't put it on a pump necessarily, but they take what's called a pressure bag, and it looks like a big bag that fits around the IV fluid. They pump it up like a blood pressure cuff, and this like squeezes the fluid into the person very, very rapidly. Eventually, if that person's bleeding cannot be controlled, there's going to be other measures to stop the bleeding at the source. If the person, if we can't get the vital signs to normalize somewhat, there's going to be a blood product replacement. And I have seen massive transfusion protocol, and that's for every so many units of packed red cells you have to give the patient. They replace other factors or components of the blood, like fresh frozen plasma. There's usually some cryoprecipitate. But that's really not important to memorize. Just be aware that shock can happen following a musculoskeletal trauma. So another complication that can follow a fracture, and I kind of want you to pay a little bit of attention to this. In fact, because I like stars so much, I'm going to put one on there. And you're going to learn to follow the stars when you're filling out your note page. Is fat embolism, and fat embolism can happen following a fracture of a long bone or a fracture of the pelvis. Typically, it follows a femur because the femur is the largest long bone in the body, or it can follow a pelvic fracture. But what happens, the bone breaks, and inside the bone marrow are fat globules, which are then released into the circulation and then embolized into various parts of the body. Typically, it can be the lungs, or it can be the brain. It can be a number of places. So the first manifestation, this is one of those things that NCLEX just loves to throw at people, and ATI does too. One of the first things is that you have a patient, and maybe this patient is 12 to 48 hours post-fracture of a long bone, say the femur. And that patient has been formerly cooperative and oriented ×4, and now this person is agitated, restless, confused. So the first thing you generally see is a little bit of altered mental status, and this is coming from early signs of hypoxemia. And you remember when we did our oxygenation lecture way back in Unit 3, we talked about signs of hypoxia. And the first thing to go is that the brain is saying, help me, something's not right here, I'm not getting the oxygen. Remember, nervous tissue is very, very sensitive to lack of oxygen. So then you're going to start to see things like tachypnea. The person's respiratory rate's going to go up. You're going to see tachycardia. You might hear wheezes, excuse me. Sister Joan would be so disappointed in my typing skills. Wheezes, you might hear rails, especially in the bases, or crackles, they like to call them. And the person might complain of shortness of breath. Okay, so all of these respiratory things. A little further out, you start to get a fever. And then this is the key. And I don't know, let me see how I can make this a little bit more exciting for you visually so you remember it. Here we go. A petechial rash that goes across the chest and the anterior surfaces. Can be in the axilla. It could be on the palate. It could be inside the cheeks. But that petechial rash is the tip-off that this is now a fat embolism and not, a pulmonary embolism that arose from a DVT. And fat embolism is one of those things that, like I said, ATI likes to throw it at you, NCLEX likes to throw it at you. You'll see it in case studies in class, but I want you to really remember the signs and symptoms of a fat embolism. So, Mrs. Mulcahy, what do they do about a fat embolism? Well, here's the sad fact, is that there's not really a lot you can do. It's more supportive management. I did find one source that said that heparin protocol could be used because it sometimes is hard to tell the difference between a fat embolism and a PE. But there's really no evidence that supports that if it is a fat embolism, that will work. The jury is still out on the use of corticosteroids to manage fat embolism. The truth is most cases will fully recover. We have to, of course, manage the airway. And oxygen, we're going to give oxygen. But most cases will fully recover on their own. There is a 15% mortality rate. The big emphasis with everything is, prevention, which is early immobilization, and reduction. And think about that for a minute, and it kind of makes sense. If we've got free-floating bone fragments and there's fat globules getting into the circulation, we can fix that by putting those ends together and immobilizing them. Okay, so that's really how we prevent a fat embolism. But knowing the signs and symptoms of a fat embolism could be important for you in terms of information that tends to show up on standardized testing. Okay, so that is fat embolism. Let's make that a little bit smaller, and we'll get rid of that star. We don't need it anymore. So the next complication I'm going to draw your attention to is something called compartment syndrome. And you'll see I gave this one 2 stars. Compartment syndrome is really, when we talk about complications of fracture and musculoskeletal injuries, compartment syndrome is something that comes up very frequently. It's the main thing that you're looking for when you assess those 5 Ps. So let's take a look at this. These are muscle compartments. And you'll see that it's like little package deals. You have a couple of muscles packed together in these little bundles. What happens in compartment syndrome is that pressure builds on that compartment. Now this can either happen, I'll get rid of that for you. This can either happen as a result of external pressure, such as a tight cast, or tight bandages, or some kind of constriction from the outside. People who have had injuries where their arm is pinned under them in a car, or oh gosh, there was that movie, I can't remember the name of it, about the guy that got trapped in the crevice for, a couple of days. and he was laying on his arm. So that can happen. That can be an external cause of compartment syndrome, or it can happen from internal causes, from swelling within that muscle compartment. And that fascia doesn't expand to allow for the swelling. So what happens is you cut off the circulation to the muscle compartment and you have necrosis and you have nerve damage, and that can become permanent. This is a limb-threatening condition. And I'm going to put that down. Resulting from increased pressure in a muscle compartment. And it can be, like I said, either internal or external. So if you don't treat this really rapidly, you can have permanent injury within 4 to 6 hours, and that is important to note. So this is why you need to know your 5 Ps, because the symptoms of compartment syndrome include pain. Now be careful. Pain can accompany fractures. However, the pain with compartment syndrome is pain that is out of proportion to the injury. It's increased with passive movement. And it is unrelieved with medication. Okay? So, when you have that kind of pain, you really need to have a high level of suspicion about what's causing that pain, because that is one of the first symptoms of compartment syndrome. We also get paresthesia. Oh, goodness. That burning and tingling and abnormal sensation. You will see pallor, progressing to a more cyanotic look. Temperature will be cold. Again, we're not getting blood to the extremity. So all the things that we talk about with decreased tissue perfusion, we're seeing with compartment syndrome. You will see difficulty with movement. Total paralysis is a late sign. An early sign would be difficulty wiggling the fingers or the toes, depending on which extremity we're talking about. But paralysis does occur. And pulselessness, although I am going to caution you, pulselessness can be a late sign. Oh, excuse me. Sorry, didn't see my error there. Pulselessness is a late sign, and sometimes you will pick up a weak, thready pulse and still have compartment syndrome. This means there is some blood flow, but it is very limited. And you can sometimes pick up pulses with Dopplers. And again, remember that sometimes a cast will obscure your pulse. So you're going to have to find some other way to look at it. Look at your cap refill and always compare one extremity to the other. And the reason we're doing that is that, say you have a patient who is elderly, maybe they've got a little peripheral artery disease. Maybe the other one is a little colder and pale too. You probably won't see that pain or the paresthesia unless they have peripheral neuropathy. But, you want to see what the difference is between the two extremities. So that, if a question were to ask you, you see that the foot in a fractured leg looks pale and you're having trouble palpating a pulse, what should you do? The first thing that you would do, just common sense would dictate, is compare it to the other leg. After that, you would want to assess all of these other factors and alert the physician. So the way that compartment syndrome is treated depends on the cause. If it's an external problem, such as a too tight cast, we're going to relieve the pressure. It's pretty obvious. If your cast is too tight, we might bivalve the cast. And bivalving the cast is simply cutting the cast down the middle, splitting it open, and then you can put it back together with ace bandages or tape, but this time it's a little looser. Maybe there's some space in between the edges of the cast. As edema goes down, you might be able to recast the extremity, but bivalving a cast will usually relieve pressure if it's cast related. If it's an internal problem or if bivalving doesn't relieve it, then we're going to do a fasciotomy. And a fasciotomy consists of making an incision through the skin and subcutaneous tissue, and then the provider will make another incision to release the fascia that hold the muscle compartment together. And that will hopefully relieve that pressure and restore circulation to the area. The wound is typically left open for 4 to 5 days to allow healing, but that's compartment syndrome, and that frequently does show up on testing of one sort or another. It is one of the major complications following fracture and following casting also. So the next complication we're going to discuss is venous thromboembolic events, and that's your DVT, your deep vein thrombosis, and your PE, pulmonary embolus. And these can happen following fractures. Typically, they follow fractures of the lower extremities and the pelvis again, and they're more common in elderly patients. The two contributing factors are bed rest and reduced skeletal muscle contractions. So those are your risk factors, which is why we kind of emphasize mobility so much when we treat musculoskeletal disorders. And it's one of the reasons that traction has fallen out of favor. So with the VTE, you're looking for all the same signs that you learned in your physical assessment course and with your other units that we've covered in oxygenation. A DVT, or deep vein thrombosis, typically what we see is one of the lower extremities is warm, swollen, red, and hot. Patient will complain of pain. The pain is worse when they walk. The pulmonary embolus is going to have respiratory symptoms. You're going to have tachypnea, dyspnea. Patient complains of short of breath. You're going to have coughing. You might have a productive cough, and the patient will be very short of breath and sometimes panicky, agitated, and confused. And when we talk later about patients who have ORIF or patients who have hip replacement or knee replacement, VTEs are also the leading complication, and so we look at preventing them mostly. And if we know that patient's going to be on prolonged bed rest, you might have heparin prophylaxis or Lovenox. They might have some sequential stockings or TEDs. The movie that I have to show you on Buck's Traction shows a patient having TED stockings applied just before the Buck's Traction is applied, but it is a mannequin. And I would caution you, when you're putting on TED stockings, it really takes a lot of tugging and pulling, and if that patient's already suffered a fracture, most of the time the doctor's going to order something that's a little less pain-provoking. Usually you will see them on an anticoagulant. So just be alert for those complications as well, and that comes up in other parts of this unit. Just, tuck it away in your brain. That's one of the complications that can occur following a fracture. Now, much later on, we have all the complications of bone healing. And when I showed you the slide about how bones heal, I didn't want you to memorize hematoma, callus, hard callus, soft callus, osteogenesis, and bone remodeling. It wasn't so much my intention that you looked at those and memorized the list in your head, but I want you to understand some of the things that can delay bone healing. Now, your older patients, your smokers, your diabetics, patients with poor nutrition. These patients, and sometimes your non-adherent patients, the ones that get up and walk when they're not supposed to or whatever, they have delayed healing. And what happens with this is that the bone does eventually heal. It just takes a lot longer. And it is important to have people who have suffered fractures to keep coming for follow-up care. And in some cases, you're going to have serial x-rays before they decide that they're done with the casting device or whatever fixation that they've used to immobilize that extremity, to make sure that that bone is healing and following the right path. Malunion occurs when you have bone fragments that are not properly aligned, and these form at a deformed angle. And most of the time this is a cosmetic issue, but sometimes it can become a factor that leads to loss of function. Non-union of bones is when the bone fragments don't ever heal. And that is really complicated to heal, and most of the time there's going to be a surgical procedure. You'll usually have an internal fixation. You may have bone grafts, and it can take months to heal. There are also, your book talks about electrical stimulation to stimulate osteoblasts to lay down bone. But preventing these complications a lot of times is about teaching the patient to have proper nutrition. They're going to have proper calcium, vitamin D, protein, iron, all of the things, vitamin A, vitamin C, all of the things that help them heal from other kinds of wounds. You're also going to have to remind them to be compliant with the weight-bearing instructions. And early reduction and immobilization, again, can prevent a lot of that. Okay, avascular necrosis. And this is a complication of bone healing that can occur, especially with dislocations. And what happens is that there is a lack of blood supply to the bone, and those surfaces get necrotic. This can be very, very, very difficult to treat, and sometimes even results in joint replacements. You can have bone grafts and sometimes surgical decompression to revitalize that bone. But it is really tough once you lose the blood supply in that bone to heal. Osteomyelitis, this is sort of worth an honorable mention. And it gets a unit of its own, so I'm not going to get too wrapped up in it, but I will put a star there because you're going to see it again. And osteomyelitis is an infection in the bone. Most common organism that's implicated is Staph aureus, not always MRSA, but sometimes. And the reason that it's really difficult to treat this is that bone is hard and dense, and it resists all of the factors that would come in and heal it. So prevention is the big thing. And again, we're looking more at open fractures as a causative, as a risk factor for this. So you really want to keep the open fractures clean and get them to the OR. There's like a golden window. I've seen sources that say 6 hours, some say 8. But they should get to the operating room for surgical debridement and cleansing of that wound as soon as possible. And they should get a tetanus shot. And they'll usually be treated with vancomycin. So the next complication that your book discusses is complex regional pain syndrome. And it's not terribly common, but it can occur. It's more common following fractures of the upper extremity, and it's more common in women. And what you typically see is burning pain, very severe, paresthesias. You might see vasomotor changes. You know, the extremity will have it either hot, flushed, and then it goes to cold and white and pale very rapidly. And sometimes you'll see over a long period of time trophic changes, such as hair growth. The skin will take on a shiny, glossy appearance. But this is an extremely painful condition, and it's chronic and it's resistant. So the way that we manage it, your book talks about external fixator devices. That certainly is not within the realm of nursing scope of practice. But things that we can do for this patient are to elevate, and we can administer medications. Typically what you see are opioids, NSAIDs, and sometimes steroids to decrease inflammation. If this goes on for a longer period of time, you're probably going to have to refer to pain management, and they'll probably add something to the routine such as gabapentin or one of the anticonvulsants. So that's something that you should be aware of as well.